Dr. Ishani, shall we start?
Yes, sir. We can start. Good morning, sir.
Good morning. Your moderator's permission I'm having. Dr. Ishani, your moderator. Shall we start?
1 second, sir. Good morning, sir.
Shall we start?
Yes, sir.
Yeah. Okay.
Due to the limited time frame provided to us, we have only discussed the ICD-10 criteria for all of these phobic disorders.
Okay. Thank you. We shall proceed.
Yes. Good morning, everybody. My presentation is on phobic disorders. First of all, what is anxiety? Anxiety is a response that prepares us either to run or approach danger by producing stress hormone. The word phobia is derived from the Greek word phobos, meaning extreme fear and flight. The ancient Greek god Phobos was believed to be able to reduce the enemies of the Greek to a state of abject terror, making victory in the battle more likely. By definition, given by Sharrock and Hales 2003, phobia is defined by fear cued by the presence or anticipation of a specific object or situation, exposure to which almost invariably provokes an immediate anxiety response or panic attack, even though the subject recognizes that the fear is excessive or unreasonable. The phobic stimulus is avoided or endured with marked distress. According to the American Psychiatric Association, a phobia is an irrational and excessive fear of an object or situation. Definition given by Ashok Singhal defines phobia as it is persistent avoidance behavior secondary to irrational fear of a specific object, activity, or situation. Epidemiology. Phobias are the most common of all anxiety disorders, among which social phobia is the most common. Most phobic disorders, other than social phobias, are more common in women than in men. Specific phobias occurs in 2.4 to 9.2% of children and adolescents with usual onset between 5 and 13 years of age. Onset is usually sudden and course usually chronic. According to NIMH, 1% to 12.5% of Americans have phobias. The age of onset is earliest in animal phobias, intermediate in social phobias, and latest in agoraphobia. Patients with social phobia have an increased rate of suicidal ideation, financial dependency, and having sought medical treatment. Signs and symptoms of phobias are hyperventilation, sweating, cold and clammy hands, blushing, palpitations, confusion, gastrointestinal symptoms, trembling hands and voice, urinary urgency, muscle tension, anticipatory anxiety, and fear or embarrassment or ridicule. Neurobiology. Phobias are generally caused by an event recorded by the amygdala and hippocampus and labeled as deadly or dangerous. Thus, whenever a specific situation is approached again, the body reacts as if the event were happening repeatedly afterwards. Subconscious association causes far more fear than is warranted based on the actual danger of the stimulus. International Classification of Psychiatric Diseases, ICD-10 criteria, defines phobic anxiety disorder under F40. In this group of disorder, anxiety is evoked only or predominantly by certain well-defined situations or objects which are not currently dangerous. As a result, these situations or objects are characteristically avoided or endured with dread. Phobic anxiety may vary in severity from mild unease to terror. The individual may have symptoms such as palpitations or feeling faint, also associated with secondary fear of dying, losing control, or going mad. The anxiety is not relieved by the knowledge that the other people do not regard the situation in question as dangerous or threatening. Fear relating to the presence of disease, nosophobia, and disfigurement, dysmorphobia are now classified under F45.2 hypochondriacal disorder. However, if the fear of disease arises predominantly and repeated from possible exposure to infection or contamination, or is simply a fear of medical procedures, injection, operation, etc., or medical establishments like dentist, surgery, hospital, etc., a category F40.2 specific phobia is considered. Phobic anxiety often coexists with depression. Pre-existing phobic anxiety almost invariably gets worse during an intercurrent depressive episode. Some depressive episodes are accompanied by temporary phobic anxiety, and a depressive mood often accompanies some phobia, particularly agoraphobia. Now we'll get to agoraphobia. What is agoraphobia? It is characterized by an irrational fear of being in places away from a familiar setting of home, in crowds, or in situations that the patient cannot leave easily. Diagnostic guidelines according to ICD-10 are all of the following criteria should be fulfilled for a definite diagnosis. First is the psychological or autonomic symptoms must be primarily manifestations of anxiety and not secondary to other symptoms such as delusion or obsessional thoughts. The anxiety must be restricted to or occur mainly in at least two of the following situations: crowds, public places, traveling away from home, and traveling alone. And avoidance of the phobic situation must be or have been a prominent feature. Signs and symptoms of agoraphobia. Overriding fear of open or public spaces, its primary symptom. Deep concern that help might not be available in such places. Avoidance of public places and confinement to home. When accompanied by panic disorder, fear that having panic attack in public will lead to embarrassment or inability to escape for symptoms of a panic attack. Social phobia. Social phobia is an irrational fear of performing activities in the presence of other people or interacting with others. The patient is afraid of his own action being viewed by others critically, resulting in embarrassment or humiliation. Diagnostic guidelines. All of the following criteria should be fulfilled for a definite diagnosis. First, the Psychological, behavioral, or autonomic symptoms must be primarily manifestations of anxiety and not secondary to other symptoms such as delusion or obsessional thoughts. The anxiety must be restricted to or predominate in particular social situations, and the phobia situation is avoided whenever possible. Now, specific phobias. Specific phobia is an irrational fear of a specific object or stimulus. Simple phobias are common in childhood. By early teenage, most of these fears are lost, but a few persist till the adult life. Sometimes they may reappear after a symptom-free period. Exposure to the phobic object often results in panic attack. Signs and symptoms. There is irrational and persistent fear of object or situation. Immediate anxiety on contact with feared object or situation. There is loss of control, fainting, or panic response. Avoidance of activities involving feared stimulus. Anxiety when thinking about the stimulus. Worry with anticipatory anxiety. Possible impaired social or work functioning. Treatment. There are 4 modalities of treatment: psychotherapy, cognitive behavioral therapy, pharmacotherapy, and supportive therapy. In psychotherapy, there is insight-oriented psychotherapy. It is superior to psychoanalytic psychotherapy. Insight-oriented psychotherapy enables the patient to understand the origin of the phobia, phenomenon of secondary gain, and the role of resistance, and enables the patient to seek healthy ways of dealing with anxiety-provoking stimuli. In behavioral therapy, there are 3 modalities: desensitization, flooding, and social skill training. In desensitization, also known as exposure therapy, is a cognitive behavioral therapy in which people are gradually exposed to the frightening object or event until they become used to it and their physical symptom decreases. In flooding, it's a more dramatic cognitive behavioral approach in which person is immediately exposed to the feared object or situation. The person remains in this situation until the anxiety lessens. Social skill training includes modeling and role playing. In pharmacotherapy, patients are given antidepressants like phenelzine, tranylcypromine, imipramine, sertraline. In benzodiazepines, clonazepam, alprazolam, lorazepam, and diazepam. Beta-adrenergic antagonists are given are propranolol and atenolol. In supportive therapy, eye movement desensitization and reprocessing (EMDR) used to treat post-traumatic stress disorder and specific traumas. Hypnotherapy coupled with neuro-linguistic programming can also be used to help remove the associations that trigger a phobic reaction. Thank you.
This brings us to the end of our seminar. We request questions from the house.
Dr. Ishani, would you like to invite any questions?
Yes, sir, to seniors, questions. Veena ma'am, any thoughts about the presentation?
Dr. Ishani, you're not audible.
I would request if there are any thoughts about the presentation, about the manner of presentation and the content.
Yeah, I just want to say regarding the treatment part, I know that this appears to be taken from an older textbook. So many of about the pharmacotherapy,
Yes.
many of these are not available currently. These are not currently available with us, right? And these are very drugs which are not clinically relevant today.
Okay.
So maybe we could update the resident about what is the current protocol, what are the current medications that we use, pharmacotherapy regimes that we use, the current guidelines. Okay.
Yes.
It takes time for these things to come in the textbook. That's all.
I think presentation was well presented, and I think that she got the topic yesterday. In that context, whatever she has managed to put up is very courageous, and I think as an intern, I would have not been able to do it so well. And she has gone through the basics. Very important to understand what are phobias. There are a lot of MCQs, various specific phobias like phobias of insects and all. There are a lot of examples. There is something very interesting known as phobia of forgetting. A lot of patients, 60 plus, they do come up. We are forgetting and we are phobic about it. So, or fear of forgetting, which we say. Like there are a lot of examples. In that context, I think she has done well. And I would like to request also to the moderator to felicitate her with a certificate.
Yes, thank you, sir.
Yes, I do agree. The presentation was very nice. Saying say she's an intern and good job. That's all.
So much, sir.
Taken by on Itni under Dr. Shobit Garg.
Any other questions, comments? Thank you, Dr. Rashani, for the presentation.
Thank you, ma'am.
Thank you. Thank you.